be recording the lecture. So that's everything for me. I'm really looking forward to hearing from our speakers this evening. So I'll hand over to Councillor Sheth, and he'll take it from here and introduce our speakers. Thank you.
Thank you very much indeed for that. So let me start by thanking you, Ali, for that very kind introduction. Today, we focus on cardiology care, which is really about healthy living and the challenge this issue poses for us in respect of increasing strain on healthy living puts on the NHS, but particularly our already stretched local hospitals in respect of our quality of life and in relation to reducing health inequalities in our neighborhoods and communities. What if we could spend less time in the hospital, but still get close attention from clinicians? Well, this is the vision of virtual wards initiative being rolled out by the London Northwest University Healthcare NHS Trust, which runs Northwick Park, Central Middlesex and Ealing hospitals. This initiative hopes to allow people to return home from hospital more quickly while still receiving specialist personalized care. To discuss what this really means for us, we are joined by Dr. Jaimin Shah and Shravan Sharma, who will explain how they are using the latest technology to transform cardiology care in Northwest London. So let me introduce you to Jaimin and Shravan. Jaimin is a consultant cardiologist and clinical lead at Northwest London, covering all 3 hospitals. He treats patients with all forms of health disease, from heart attacks, heart failure, to heart rhythm or disorders. He's passionate in looking after patients with heart failure. Shravan is Senior Transformation Lead at Northwest London and is currently leading on development and implementation of virtual wards and digital clinical pathways. He has 20 years of clinical experience working across various different sectors. He has worked as a clinical nurse specialist in clinical care and CQC implement manager before moving into the transformational role. So, Jay and Shravan, I know how incredibly busy you are, but really looking forward to hearing your presentation. So, over to both of you, please.
So I think I'm going to kick off. So my name is Jay Shah, as Ketan had said, and I can't thank you all, especially Ketan, for the invitation to come out and talk about some of the transformative work that we're doing at London Northwest, and hopefully give you a flavour of some of the results that we're getting from utilising digital health in caring for our patients. So as Ketan said, I'm a consultant cardiologist. I do a wide variety of expertise in looking after patients, but my real passion is in patients with heart failure. Brent is a very diverse community, and there is a lot of health inequality that is within Brent, Harrow and Ealing, which is where we cover. And I've been working very hard and very closely with the sector, with Northwest London, ICB, to try and join up work between the community and secondary care as well. As you know, heart disease is very prevalent, and currently in Brent, latest statistics from British Heart Foundation, there are about 28,000 people within Brent who are surviving, living with heart disease and circulatory disease. That includes people that have survived heart attacks, and I think that's one of the important factors. In 20 years ago, people who have had heart attacks would not survive. And because we've become better at treating heart attacks, people are living longer and then developing the longer, later complications, which include things like heart failure and rhythm disorders like atrial fibrillation, which all build more problems with comorbidity and illness as people get older. And so, you know, there's no point in trying to make people live longer if we can't deal with the root cause of the problem. And that's why we've been working so closely with primary care and community to try and improve care of people before they actually develop heart problems. So that includes things like controlling blood pressure, controlling diabetes, controlling cholesterol levels, lipid levels, particularly in those patients that have already had problems. And so heart failure, which is a very big problem going forward and is likely to only get more and more prevalent as we go forward, we came up with an idea of trying to manage these patients at home rather than within the hospital setting. I'll hand over to Shravan to give us a little bit more information about the transformation work that we're doing. But we really want to make this very interactive. So please do type questions and we'll answer as many of those as possible, and try and get to the bottom of any questions that you may have. Shravan?
Thank you, Jay. Before I start, we've got a hand up. So I think
Francesco, thank you very much. Shall we take your question after we've heard from Shravan? Is that okay, Francesco?
Yeah, just very quickly. Sorry, I got here late. But what I would say is, after out of hospital cardiac arrest and 2 weeks in an induced coma, 6 weeks in total with an ICD implanted, and coming out with the New York Heart Association class 2 heart failure and a mitral valve leak. But the one thing that's been my saving grace, because there's no way I want to work towards end-of-life care with heart failure, is cardiorespiratory fitness. My VO2 max, increasing my capacity, and I do what I can in terms of fitness. Now, I know my medication is doing part of the job, but I don't like getting up in the night using the DAPA medication to stop the buildup of sodium in the kidneys. So I think in some ways, having personalized care for each individual, and I appreciate not everyone can necessarily do the exercise, but you can do exercise at home with resistance band. While we had COVID, with heart failure, with the REACH heart failure, cardiac rehabilitation, all of it was done with videos. So I think there's other ways to deliver services, because I don't think we'll ever. Okay,
Francesco, that's really helpful. Thank you very much. So let me just bring Shravan in to find out how this new initiative is unfolding, and then we will take some more contributions from our friends from the screen. Thank you very much, Shravan. Good evening to you.
Good evening, Ketan, and thank you for inviting us. But very importantly, thank you for all of you for your time to come and listen to this, because it's important we listen to you and make changes if we can accordingly. And thank you for all the technical support in organizing this event, to everyone, including those who are involved today from Advocacy Project. So first of all, as Jay mentioned, heart failure being one of the long-term disease, and with a significant number of our people having this disease, means a lot of hospital admissions they have frequently coming into hospital. Importantly, what it also means is they go a lot of times to their GPs, because every now and then simple infections, simple fluid in their lungs, which means they need to see a healthcare professionals. It also means they need to have time to go and see those professionals. It also means they need to make adjustments for transport, etc. So a lot of health burden for a long-term disease like heart failure it brings to those who suffer from it, but also those who care for those who suffer from it. Working with Jay and the team, during the time of pandemic, we thought about this idea and set out an ambitions to say how we can care for long-term conditions, but also some of the acute conditions through virtual wards. And it's important because first, the care can be delivered close to patients on home, and being in your home environment when you are unwell, but if you can receive the care which is specialist-led and interventions at your own home, then clearly there is no substitute to it. But very importantly, I think we all know going to the hospitals, particularly during the time of COVID, meant a lot of people were scared and had feared that they will contract things like COVID at that minute in time. So I will take you through our idea on why we thought it was important and what we have, our journey essentially so far from that concept to where we are, and then we'll take your questions. So if you can share some of the slides, please, which I sent earlier.
Cleo will just helpfully start sharing those slides, Shravan. Thank you, Cleo.
Thanks very much. So next slide, please. So just a little bit of background, as Jay and I have mentioned, but one of the things which we were concerned during the COVID time were a lot of patients with heart failure were not coming to hospitals because obviously there was fear that they will catch COVID and this could be catastrophic for their outcome. Of course, hospitals suffered a limited capacity, but also at the same time, not just during COVID, even before COVID, we knew that waiting times for specialist care were prolonging. So patients had to wait longer time for any specialist reviews, and that was becoming a concern for us. Clearly, patients, if they don't get care in right time by the right clinicians, of course, that would mean they would come to hospitals being unwell more frequently. And when they come into hospital, they would stay longer than if they were to have timely care. So clearly, with all of this in mind, we set out an ambitions to say how we can bring the care close to our home, but also importantly, how we can make sure using technology, we can help our patients to know more about their disease condition, to know about the symptoms which are important to be aware of, and to manage their day-to-day life condition. Because when we think about a long-term disease, I think a bigger part of this is about how much we know about our own disease and how we can manage, and when are the things and the concerns early trigger we can identify so we can seek the right help. So with this background and context, then we moved on to the next slide, please. So virtual wards, as some of you may have heard, is essentially a concept where we monitor our patients remotely, our clinicians, specialist nurses, when the patients are in their own home, using the technology. They are still being cared for by the specialist team, and Jay, as a cardiology consultant, still oversees the care of these patients. Of course, the care is close to own home, but also we know that when patients are in their own home, there might be time where a clinician needs to go and see them. If there are concerns, we identify through what we have looked at in terms of the symptoms the patients have told us, in terms of the readings, we see the serial readings and how a patient condition have changed. And particularly if there has been a concern from a patient's point, what a message they have sent us. So if there are concerns, then we would go and see them in their own home. So essentially this entire concept is a virtual ward concept. Can we move on to the next slide, please? So we started with heart failure virtual ward, of which very recently we celebrated in a way our second anniversary, because we went live on 19th of July, 2021 in the middle of pandemic. And from learning from this concept, essentially we have built 4 more virtual wards at this moment in time. So there is a virtual ward where we care for patients with respiratory illness, patients for diabetes, patients who have got infections and need antibiotics, and a virtual ward for children. And when we think about it, one obvious question which will come to somebody's mind is, why these particular virtual wards and why not something else? And one of the reasons we have focused is when we think about the diverse population we have in Brent, Harrow, Ealing, particularly Northwest London has some of the very diverse populations in the country. But also same is true that heart failure, respiratory illness, and the diabetes are some of the most prevalent long-term conditions in our communities. So it's important to focus on the right thing, and that's why we focused on these pathways first to begin with. Can we move to the next slide? So the next question probably will come to your mind is, how does the process work of the virtual ward? So what happens is, if a patient is coming to our hospitals, whether they presented to emergency department, whether they came to outpatient settings, or whether they are an inpatients, based on the patient's conditions and clinical criteria, our clinician will speak to the patients, discuss this concept with them, and they will download an app on their phone. The app is purpose-built, so it's not like a company has given us a format of the applications. This is an app which our clinicians, cardiac nurse practitioner Jay, including multidisciplinary team, have built a set of questions which are important for us to be able to identify progress on patients' conditions and identify any other triggers. So these are the purpose-built app. These are not the supplied app by a manufactured company. What then we do, we will give a set of equipments to the patients, so particularly the blood pressure measurements, as well as the weight in terms of the heart failure, because these are the two important things we need to know for heart failure patients. But in some exceptional cases, some other equipments may be given for those group of patients. I must say that most of our patients with heart failure, they know how important it is for them to monitor their weight. So most of them have their weight machine. Of course, then we advise and go through the patients about what sort of questions they need to answer. So, as you can see, I don't know how visible it is on the screen, but it's a simple set of 5 to 10 questions they tell us every day. And then based on those set of questions, we get to know how they are improving. Do we need to change anything? And then we would call them up to make necessary changes. Patients can always communicate with us if they have concerns through app messaging. And there is a sections within the app where they can learn more about their conditions, investigations for heart failure, a varied level, things like echocardiogram, ECGs, and other investigations. Next slide, please. So one thing which would come to our mind is, of course, bringing care closer to home is ambitious, important, but at the same time, what is equally important is patient-centered quality care. And for that reasons, these are the 6 things we have focused right from beginning. So we want to make sure that care is safe in our virtual wards, care is effective, it's patient-centered, it's equitable. What we don't want to certainly do is offer health inequalities by introducing a new way of working. It has helped us improve the care of those who present to emergency department by bringing our patients to right setting, but also importantly, to make the care sustainable. Next slide, please. This one I will let you read. This is some of the feedback we have received from our patients. This is just a snapshot of what they say about the care they receive. Of course, we monitor and capture their feedback on day-to-day basis and act on what they say is.
And of course, apart from what you have on the screen, Shravan, we also just had Gloria Golding say how useful she has found this to be from her own experience. So thank you very much for sharing your experience, Gloria.
Thank you. Thank you. That's really, I'm really pleased to hear. Thank you. Next slide, please. I think we are moving towards the end. Some of the big achievements in the last 2 years, our virtual ward has actually won international awards in the way the things have been delivered, with a concept of keeping patients in the focus. Department of Health and Social Care. They shared our practice as a best practice. We were also one of the finalists for Future NHS Award recently in a parliamentary award, which is essentially focused on how the care needs to be delivered in a sustainable way in the coming futures, as well as the Health and Safety General Awards. So these are some of the things which are, but I think most importantly, what we are proud of, what patients tells us day-to-day basis. What, for example, having a real life feedback from Gloria is probably most valuable to us than any of it. And that's all, essentially. We will take any questions, but
Thank
as
you.
a snapshot.
Thank you very much, Jay, and indeed Shravan, for that fantastic overview. Certainly, I have learned a great deal in a very short period. I'm sure equally this has been helpful to many of our friends on this Zoom screen. And thank you again, Gloria, for sharing your experience this evening. So we have heard quite a bit from both of you, Jay and Shravan, about the importance of prevention and also how prevalent this is amongst our communities in Brent and other parts of Northwest London. So having had the overview of the new emerging care pathway, I wonder if you could just go on to say, how are you going to be developing the virtual wards going forward, and perhaps with the collaborations of I think that for many of us, the first port of call is our GPs. So how are you going to be collaborating with the GPs to drive forward the prevention which both of you have referenced? Jay and Shravan, please.
Prevention point of view, as I said earlier on, we've been working very closely as a sector, and we've worked on several different projects to try and improve prevention within the community. For example, I'm the ICB lead for lipid optimization for patients who have familial high lipids or have had previous cardiovascular events who need to be on statins to try and prevent future events. And we've been working with PCNs to try and optimize patients. We've been doing similar work with high blood pressure, doing case finding, as well as optimizing blood pressure management. And most importantly, really exciting for me is we've set up and started a project in Harrow with one of the PCNs, in Brent with one of the PCNs in Brent, looking at putting patients on remote monitoring in the community with heart failure, so that we can identify and pick up any decompensation or worsening of heart failure early before they actually need to come into hospital, and try and treat them early so that we don't end up having them coming to the hospital either as an inpatient or even as an outpatient. So that there is a sense of camaraderie and common goal in the sector, that we're all working to get towards the same goal.
Yeah, just to add. Sorry,
thank you, Jay. Shravan, please.
Yeah, so just to add from what Jay has said, the first of its kind in our knowledge where GPs from their practice identify the patients who needs the day-to-day interventions and early identifications of the disease, and then we can have the specialist input of those patients. In our knowledge, that's the first kind of things nationally. And what our ambition is, learning from that, we would then want to work with our primary care and community teams to see how we can scale it, not just particularly to one GP surgery, but across the board. But at the same time, as Jay alluded, we work in very close partnership with Imperial, Shalwest, and Hillingdon. So it's not then the good thing which we can do as clinicians is not limited to one particular area, and that we address it as an equitable access to anybody who's living in our boroughs.
Thank you. But before I bring Robin in, we had a really good question on the chat a few moments ago. And of course, this is all very positive. And of course, as I've said a few moments ago, we have heard from Gloria how she has found it useful from her own experience. But the question was on the chat, how do we then ensure that all of this, of course, is very good, but you know, it being virtual, how would you be able to ensure that infections and issues perhaps may be seen in person is not missed? Jay, Shravan?
So the app allows direct communication between the clinician and the patient, and we have fixed triggers as well, and we've built in the protocol, in the process, that if a patient needs or wants a face-to-face review, we will organize that and sort that out. And because there is daily communication with the patient, it's much faster and much quicker to organize, because we control all of this. So the direct communication is invaluable in this sort of situation.
One more thing.
Thank you. Shravan, please.
Yeah, just to add from what Jay mentioned, so the set of questions which are asked or the patient normally responds in the apps are very sensitive for us to be able to identify early deterioration. And I've used the term carefully, early deteriorations. This is about how your shortness of breath had changed from yesterday to today, and then again tomorrow. It's about how was your weight yesterday, and now it is today and tomorrow. With those trends, it allows us a better clinical decision making sitting remotely, but also allowing patients to have any concerns as a free text, say, I'm worried about my particular, this issue today, which then triggers perhaps a telephone call, for example, where they can gather more information if the information which has come through the app is not sufficient or we need to gain more. And based on that, either somebody will go and see them at home if it is sort of low level of concern, but if it is a high level of concern, we would bring them electively into our same-day emergency care, where our teams will see them, do all the relevant investigations, and then decide whether they still need to be in virtual ward and can be safely cared for, or we need to admit them in hospital.
That's really helpful. Thank you very much to both of you. Let me bring...
Sorry, Kevin,
sorry, Jay.
Just because this ties in with one of the questions that Mr. Palmer had put in the chat about you can't treat breathlessness and fluid retention with an app. But actually what the app does is trigger us to optimize their medications. And we have fixed touch points with the patient to optimize medications based on their observations. And the idea is that we can optimize their medications before they actually have their decompensation event. And we know that getting the patients on the right medications at the right time and as quickly as possible to the right doses prevents problems in the future. And that's the whole point of the virtual ward. It's not just monitoring, it is about treating as well as monitoring.
Thank you very much for that. Grateful to you. Let me bring Robin in, and then I'll come to James. Robin, good to see you. Thank you very much for joining.
Thank you, Ketan. I'd like to thank the presenters for a very clear presentation and a very positive message that they're getting across, and for the good work they're doing, because obviously where people can be treated at home in this way with securely and safely is a gain in every way, both to the hospital and to them and their families. But I'd just like, if I may, to ask a broader question related to cardiology, as I do have a condition in personal experience. So I have atrial fibrillation, And I discovered this I was taking part in a study run by Michael Marmot called the Whitehall 2 study over 25 years, and it carried on after you retired. So in 2015, I went for my session, and a couple of days later, I was telephoned to say, we did your test on you, and you're suffering from atrial fibrillation. I hadn't a clue what that was. I'd never heard of it, and they had not any symptoms. And I had great difficulty in accessing NHS clinic that Brent were running a community clinic. And so I went to see someone under my own arrangements. And this eminent cardiologist said, you don't leave this building tonight without getting your dose of apixaban. And I've been taking it ever since. That's 8 years now. And what strikes me, of course, is that there's a substantial number of people in the community who do have atrial fibrillation, are at risk, and don't know it. And I wonder what more we can do to screen people who are in any way likely to be suffering from it, so that they can take preventive measures. Exercise is all good and so on. But I can tell you, if you do have the condition, it's best you know about it and take the appropriate medication as soon as you can. I don't know what our colleagues would say to that. Thank you.
Thank you, Robin. That's a really good point. Thank you, Robin. Jayan Shravan, please.
So from the point of view of increasing the detection of atrial fibrillation, there is a lot of work that's going on in the sector and within the trust as well. So within Northwest London, there's a lot of work in trying to improve detection and treatment of patients with atrial fibrillation, which has resulted in sort of pathways that have been developed to try and quickly identify, quickly initiate treatment, and quickly manage the patients in a way that prevents them from having to come into hospital. When the blood thinners initially came out, general practitioners were very unkeen to prescribe these medications just because of the fact that they weren't used to it. But now most GPs will initiate these medications themselves without having to refer them to specialist centers for further assessment and blood tests and things like that. So undoubtedly COVID did put a lot of challenge in being able to identify patients with high blood pressure, with heart failure, and treat them. But we're working very hard to make sure that we can improve all of that across the sector. We've been doing a lot of education work for AF, high blood pressure, lipids, etc., with primary care to help support them with secondary care to detect and manage these patients as soon as possible.
And let me just ask a supplementary. You just mentioned education, Jay, and I am keen to understand. So obviously this is a really new concept, emerging concept, and I wonder how much of education or how much of communication has been to get us over our initial fears, please.
So when I talk about education right now, the education is between secondary care and primary care.
I get that. I get
upskill,
that. But I'm just broadening to perhaps much more wider sense in education and communication.
So with that in mind, that's what the key focus has been at the moment. But there are plans already penciled in to widen that out to general public as well, to try and increase education for general public. So we, Mr. Palmer was talking about cardiac rehabilitation and the education and support that provides to patients with heart disease. And actually, we've been very lucky to have won money from NHS England to set up a cardiac rehabilitation service for Brent patients and provide that service to Brent patients with both heart failure as well as coronary heart disease. So people that have had heart attacks and stents and things like that put into them. survived out of hospital
Thank you.
cardiac arrests, etc. So this is something that we've been really focusing on, so that we can improve education for patients as well, so that they can recognize things like atrial fibrillation, and the importance of being able to treat those things, recognize symptoms that should be concerning, and allow them to be able to access care quickly as well.
Thank you for that, Shravan.
Yeah, I think, Ketan, your question and Robin's questions, they raise some very important element from people who live with these conditions. And Robin, I liked your advocacy essentially for a condition you have been living, because people, if they need to identify the day-to-day symptoms of somebody having AF, but not knowing that they are living with AF, it would be certainly helpful for an early identifications. But one thing I think, just to add, a lot of patients who are above 65, if they go to hospital and get admitted, one of the things which we do as a standard is we do an electro ECGs for them. So that is an opportunity for only those who've been admitted and have been unfortunate in some ways to be in hospital, but that allows us to identify, because we know those who are over 65 are slightly higher risk because of many different reasons. The second thing is, of course, we don't want everybody in the hospital, but a lot of people may still have with AF and living. And that's where Jay's element about how important it is to be able to identify these symptoms, simple dizziness, simple palpitations, kind of things. As much as the focus has been on the preventing complications of AF and other things like stroke, I think we need to acknowledge this. There hasn't been a greater emphasis as much on identifying or creating public awareness for AF. But I think the opportunity of digital pathway allows us this sort of way to create a public awareness where we can create public resources, for example, within the apps, health apps, which allows people to know about these particular conditions. What could be the signs? I'm living with heart failure, but I may have AF, and these are the signs you have if you have AF, and that allows then that quick partnership. Ketan, I'm going to take one more minute to address a previous question, because I think it was very important.
Thank you.
That app doesn't make the shortness of breath better. I think it's so important to address that. So as Jay mentioned, one of the key things our teams do day-to-day basis, they will monitor the patient's symptoms and change their medications, therapy, to make sure those symptoms are controlled. So it's not that we just monitor them, it's what you do as an intervention. And just to give you some concrete figures of how important and effective this has been, generally when a patient with heart failure gets diagnosed and they go on to have optimizations of the therapy, so generally they would go on to 3 or 4 different medications. By the time they go on to have the highest tolerated optimization therapy, with evidence what we have, it may take up to 6 months, because they have to go to GP, then after 4 weeks they have to go to another GP, then after 4 weeks you go to another GP. So the change in frequency in therapy is so widened that every 4 weeks. In our virtual ward, the optimization therapy is achieved in 6 weeks. And for how many patients? Nationally, there are 49% of the patients who are living with optimized therapy with heart failure. The patients who have been on a virtual ward, 70% of those patients go on highest tolerated optimization therapy. So there is a clear evidence that day-to-day interventions on increasing, titrating the doses to make those symptoms and therapy better is much more effective, not for the patients, but wider NHS importantly as well. So something very important I thought I shouldn't miss to give a message.
Thank you. That's really helpful. Thank you very much. Let me bring James in. James, thank you for your patience. James?
Oh, it's a really helpful session, and the project is really commendable. The point I was trying to pick up, I'm an Ealing person. No, sorry, something's just going wrong. Can you hear me?
Yes, we can.
Sorry.
Thank you, James.
I was trying to learn my hand and I did something else stupid. Ealing a few years back, 2014, this is in borough level CCG, started a community cardiology contract, and it went out to tender, and Northwest and Imperial were the two consortia, and by chance I was the patient rep on the process. So I became aware of this. Then more recently, a few years ago, a lovely member of my patient participation group who had existing cardiology issues had a problem, declined an ambulance, went to the GP, saw a locum, and was put into the community cardiology service and was in the queue waiting for diagnostics, etc., had a further episode which was terminal. And I'm just thinking, because of the similarities between what we're hearing today and the learning there must be from that local borough Ealing service, which overlaps with the catchment area of the hospital trust, how can we try and share what learning from that early experience, because this is a really good initiative, and how can we make sure that it's catching all the glitches that seem to happen? I'm not going to go on about them, but the person who died was a close associate of mine, and because he was a widower, he shared with me his medical history while he was waiting for further treatment by the Ealing Cardiology Service, and then died before it could take place. So can I connect with somebody who's administering this service? The advocacy guys have got my email address, but I'm happy to put it in the chat, and I'd just like to sort of see how we can see what to a semi-lay person could be learned from what I observed.
Thank you very much, James, for your question. And Shravan and Jay, perhaps you could do it in a way that which is much more broader point, which arises from James's point. How are we learning lessons from other virtual wards which are being rolled out in other areas?
So if I can, Shravan, I'll start. Thank you for that question, because it's really important that we're able to sort of demonstrate that we're providing the service to all of our boroughs that we serve, and not just Brent and Harrow or Brent alone or anything along those lines. This service is a service that spans both of the acute hospitals, and so actually most of our remote monitoring work is based in Ealing Hospital. So the clinician that will be doing the remote monitoring will be doing it at Ealing Hospital. We have nurses that go out and pick patients with heart failure on both sites to identify them early, and then try and identify who is suitable for our virtual ward and get them onto the virtual ward. But more importantly, ensure that there is appropriate follow-up care for them. So, for example, some of the patients are patients that are already known to the community cardiology service. And if they are already known to the community cardiology service, usually the patient themselves would like to go back to the community cardiology service rather than be on the remote monitoring app. And so we make sure that we actually liaise with the community cardiology service very closely to ensure that there's a clear path for them to go back to the team, to ensure that within a couple of weeks they're seen and optimization occurs. But we also ensure that they have contact available with our heart failure nurses as well at the same time, while we're waiting for that gap. So again, we work very closely with Ealing itself, but similarly in the sector, the virtual wards is a really important initiative, and we're trying to roll it out in all of the trusts and providers, so that we can provide similar service throughout the sector. And there are successful virtual wards in other parts of the country, particularly for heart failure, particularly up north in Manchester, I think it is.
Thank you.
So we're all working very closely together to try and ensure that we can learn from each other and implement changes and actions that would help. And in fact, our learning has helped Imperial start their virtual ward as well.
Great. Thank you very much for that, James, and thank you, Jay, for that very helpful reply. Let me bring Francesco. We've got about just over 5 minutes, and I'll try and get as many questions as I possibly can. Francesco, thank you very much. Good to have you on the Zoom call this evening. Thank you.
Yeah, thank you. I'm aware of virtual wards for heart failure. That's a new initiative across England. But in my time, when just before COVID, the community heart failure service was sent on the front line to deal with COVID. One of the mistakes that they made as someone that was newly diagnosed with heart failure is how to manage your symptoms, because there was nothing from the first lockdown right through to September. So people had to manage. And I had my ferrous iron transfusion delayed by 6 months because I was anemic, which is quite common with heart failure patients. I'm not knocking it. And one thing I would say is, in all fairness, 80% of patients with a diagnosis of heart failure as a result of unplanned activity into A&E. So if you're able to pick up on some of that in primary care, because let's face it, NHS self-checks for the 40 to 74-year-old wasn't fit for purpose, but it had, it was able to do a few things, but not many. So if you can pick up on that and you can show the evidence and data to support the contention, there's fewer patients, ending up going into hospital, down to 60% as over 5 years. Then in your area, then I would say that's absolutely fantastic. So best wishes with that. I don't need my GP. I've not seen my GP since my cardiac arrest. I feel confident in the people. I've had elevated triglycerides. I keep having blood tests, but I've not had. I've had medicine optimization. There's been no changes, but cardiorespiratory fitness moving away from potentially, because I had 2 arrhythmia nurses come to speak to me about end of life care. What the hell do you want to speak to me for? I got no plans to go anywhere. So I've moved myself virtually to stage 1 of the New York Heart Association scale for heart failure. I've got no plans. I'm here. I'm here. Thanks.
Thank you very much for that. Really, I'm grateful to have that very personal experience that you have very eloquently shared with us. Thank you very much. Jay and Shravan, let me just ask a couple of quick questions before we run out of time. So I'm keen to understand a little bit about going forward. How about the potential? So, what are the potentials to drive down those prevalences that I was alluding at the outset across various different health issues? We've talked about heart attack quite a lot. What about stroke? What about dementia? What are the potentials for these virtual wards to drive down other prevalences, which are perhaps also pretty high amongst our communities?
So I think part of the problem is that the stuff that we're doing right now, the ship has sailed, because they've already had their heart attack, they've already developed their heart failure. And the way that we're going to drive it down is by trying to treat those risk factors that cause the problems. And as I was trying to allude to earlier on, we're working incredibly hard with the whole sector in trying to make sure that we case find patients with high blood pressure that haven't been diagnosed but are living out there with high blood pressure. And it is estimated that only about between 40 and 60% of patients who should be diagnosed with hypertension are on a GP register. So there's a vast population out there who are living with high blood pressure but don't know about it. So there's a big push, and just a couple of weeks ago there was a big webinar with the whole of London, not just Northwest London, trying to promote the big case find, looking for patients with undiagnosed high blood pressure and initiating treatment for them. So that's where this all comes. that we need to be doing. It's before they develop this illness, rather than after they've developed the illness. That's how we're going to drive down the prevalence.
Thank you. And Jay and Shravan, we have talked about great deal on technology, and of course there'll be some proportion of population who will fear the technology, or perhaps will not have access to the technology. And if they do, they'll have other barriers, cultural barriers and other barriers. And how are we ensuring, when you talk about that big push, Jay, that you just referenced, how are we ensuring that we are also getting that big push among some of those individuals, perhaps who might not have the ability to benefit from this great initiative that we've been hearing about?
Shall I take this? Yeah?
Yes, please, Shravan.
So I think first thing is, before we rolled this out, we carefully assessed the impact of it in terms of equity in the healthcare access, and what could be the impact on those underprivileged people in the community. One thing was evident, that those who don't have access to technology, don't have money to buy a smartphone, can't afford to pay for internet, even though they may be somebody who can benefit from this, that puts them at really disadvantageous position, isn't it? Because, and that's not what the NHS should do, because that's the founding principle, equity in access. So with working with that principle, we are really proud to say last year we ran a sort of proof of concept idea, first of all, working with our digital partners and Apple Academia on providing access to those group of patients through an Wi-Fi enabled iPad, which allows them access to use this app for the period of time they could be managed on virtual ward. And of course, once their stay is finished, their device will be collected. And I'm really pleased to say we have rolled that project now, not limited to heart failure, but for other conditions where what we want to make sure is no one is left behind in any sort of initiatives. Just to highlight some key figures for everyone's attention, very conscious of the time. In fact, if we were to look at our demographics of the patients we are serving through a virtual ward, somewhere around 50% of our virtual ward population comes from Asian background. Somewhere around 40% comes from white ethnicity, and around 15% comes from Black and other ethnicities. In terms of the different age groups, around 45% of our group comes, well, not 45, in fact, 48% over 65. So what first thing we want to make sure is you monitor who you are serving for, because if you can't do that, then you wouldn't know who you are not serving. And that's what we are trying to do.
Thank you very much. Those who are regular to this monthly events will know, I always say this, that 1 hour is never going to be enough for hugely important topics that we bring each month. But as I always say also, that this is just the beginning of conversation, and we'll try and bring perhaps part 2 some months later. But thank you very much indeed. Let me hand you back to Ali for her quick final word or two, please. Ali, please.
Thank you, Ketan, and huge thank you to both our speakers and to everyone that has shared their personal experiences and asked really thought-provoking questions. It's been really interesting and such a powerful discussion, and fantastic to see such innovation in our community. And I did have that one question about the sort of digital access, so it was great to hear about that piece of work as well, that actually people do have access to the digital technology that is supporting this. So thank you to everybody who has attended the lecture tonight. We will send out the recording and that will be also shared online, and we'll also share details of our next lecture. So thank you everyone, and wish you all a lovely evening.
Thank you.
Thanks everyone.